So, TRK fusion cancer is a rare disease, also in pediatric oncology. There are rare tumors with a very high TRK frequency, like congenital infantile fibrosarcomas and mesoblastic nephromas, but also more common pediatric tumors with a very low TRK frequency, like sarcomas, high-grade gliomas, and so on. This study showed a very massive, large overall response rate of 94% with a high CR and PR rate. At the same time, the safety data was quite good. The toxicity is very mild. You see some neutropenia once in a while. You see some mild fatigue or weight increase, but no really significant toxicity, and all toxicity is well manageable, especially if you compare it with standard therapy, which is at the moment chemotherapy or radiotherapy. Of course, the study is still ongoing, so we don't have long-term data yet. But a significant amount of patients, especially the congenital infantile fibrosarcomas, have had a tumor resection after initial treatment with Larotrectinib. So in this neoadjuvant setting, the tumor shrinks very fast, so within 2-3 months, and after that, the child or the baby is amenable to non-mutilating surgery. If you are able to completely resect the tumor, we now see that the response seems durable, although we still have a short follow-up. So that's something which probably holds true also in the longer term. But for non-completely resected or non-complete remissions, the data has to evolve further first. I think I should refer back to the previous question, in the sense that I think that in many cases, Larotrectinib should be used to shrink a tumor and then resect it. If you do that timely, you won't probably have the problem of resistance, because you don't have the time to develop it. At this moment, we see patients who have had previous lines of therapy, who have advanced end-stage disease, who are not amenable to surgery anymore, and if you treat them long enough, they have an increased chance of resistance. So I think in the future the resistance problem will get smaller, because we will treat the patients earlier with Larotrectinib. But exact data about the occurrence of resistance is not available at this moment. It occurs, I've seen it myself in several patients, but the frequency and at what time point is not known yet. This drug is now given to babies who sometimes are even still only a month old. Very efficacious, but the long-term toxicity is of course not known. The TRK protein is involved in neurological development, and so it will be very important on the long term to see if there are any neurological developmental problems or cognitive problems in these very young children. This is one important point. Furthermore, the point of resistance is of course very important. We need to see how often this occurs, and if there are new generations which are already upcoming of drugs who are able to even be better at this point. And last thing I think which is important to learn is when to stop a drug and if the response is still durable if you set off treatment in, for especially the not complete response patients or the partial response patients.